Hello, I'm Faizan Nazarian from Mercer University, Atlanta. My advisor is Dr. Rakibul Hassan. Our research shows how statins directly regulate cerebral artery contractility and its underlying molecular mechanisms. Statins are cholesterol-lowering drugs that have been clinically used for more than 30 years to prevent and treat atherosclerotic cardiovascular diseases, including hypertension, coronary artery disease, and stroke. Statins are known to have a range of beneficial vascular effects, such as inhibition of endothelial dysfunction and reduction of smooth muscle cell contraction, proliferation, and migration. The conventional belief is that these beneficial vascular effects arise from the inhibition of mevalonate and cholesterol biosynthesis and the inhibition of mevalonate-dependent Rho kinase signaling, a process that takes a long-term treatment, ranging from months to years. However, whether acute statin treatment can directly influence contractility of resistance arteries, such as the small middle cerebral arteries, is unclear because previous studies used supertherapeutic concentration, which is at least 1,000 times or fold higher than the mean plasma concentrations. They used conduit arteries that do not control regional organ perfusion or even systemic blood pressure. Previous studies also use cultured arteries and cells that do not simulate physiology and use male animal arteries, overlooking sex-specific differences in statin action. Now, to answer the question of how we can take this work into the real world by investigating the direct effect of therapeutic concentrations of statins on cerebral arteries from both male and female rats and characterize the mechanism of action. Using fresh isolated middle cerebral arteries, we performed pressure myography that allows us to track vessel diameter and calcium and contractility system that allows us to simultaneously track vessel diameter and calcium level. That way, the outcome of this work could allow for more effective, safer, and personalized statin therapy. Our pressure myography and calcium imaging data for the very first time show that therapeutic concentrations of statin elevate intracellular calcium levels and produce huge constriction in cerebral arteries within 2 to 3 minutes after drug application, as shown in Figure 2A. Figure 2B demonstrated that statin produced significantly greater vasoconstriction in male rat cerebral arteries, which indicates that sex-specific differences in statin actions may exist. And now referring to Figure 3, we found that statin-induced cerebral artery constriction is not affected by endothelium removal. This means that the action is endothelium independent. And now Figure 4 showed that mevalonate supplementation did not alter statin-induced cerebral artery constriction, which means that such vasoconstriction does not depend on HMG-CoA reductase inhibition, mevalonate reduction, or even Rho kinase inhibition. However, statin-induced constriction is fully reversed when extracellular calcium is removed or when CAV1.2 is blocked with nimodipine and SERCA is blocked with tupsigardin, suggesting that extracellular calcium entry and subsequent intracellular calcium release is critical in this process. Application of ranitidine actually had no effects on statin-induced contraction. And now finally, Figure 5 shows that siRNA knockdown of myocyte CAV1.2 ion channel, which reduces calcium 60K plus responses, fully reverse statin-induced vasoconstriction. Altogether, our data suggests that nanomolar statin stimulate myocyte plasma membrane, L-type calcium channel, and calcium influx into cerebral arterial myocytes, leading into vasoconstriction. Now, finally, to answer the last question, if COVID affected how our research will apply to the real world, is yes, COVID did, because COVID causes vascular inflammation and cardiovascular dysfunction. Our data from Figure 4 show that statin-induced contraction of cerebral artery is completely abolished by nimodipine, which is a selective CAV1.2 channel blocker and is widely used to treat hypertension. This finding suggests that patients requiring statin therapy may still benefit if CAV1.2 mediated vasoconstriction is tackled by concomitant administration of CAV1.2 channel blocker, such as the nimodipine. Since many patients receiving statin therapy may have coexisting conditions, including hypertension, these patients may already be on calcium channel blocker for treating hypertension, thus are unlikely to be affected by statin-induced CAV1.2 activation and vasoconstriction. However, this may be of concern when a statin therapy is instituted in normotensive or relatively younger patients for treating familial hypercholesterolemia, as these patients may experience undesired side effects due to a direct action of statins of CAV1.2 causing constriction of cerebral artery and aorta. With that being said, this is the end of my presentation, and I hope you enjoyed it. Thank you for your time.